Bismillahirrahmanirrahim. Good morning, everybody. We are continuing our series of lecture about neurological emergencies. Today we will discuss a very important topic that we see a lot in ER departments, which is acute vertigo or approach to a patient with acute vertigo. First of all, we would like just to differentiate between two overlapping terms, which are dizziness and vertigo. Dizziness or lightheadedness is a general term used to describe a range of sensations, such as feeling faint, woozy, weak, or just unsteady. Vertigo is a false sense that you or your surroundings are spinning or moving. When the patient comes and tells, I feel dizzy, I feel vertiginous, I feel unsteady, you have first to differentiate between both. You ask the patient whether his complaint is just unsteadiness or feeling dizzy, or he feels that himself or the surroundings are moving, or as if he is riding a roller coaster or something like that. Okay. After that, moving to the causes. The causes of vertigo could be peripheral and could be central. Peripheral causes include motion sickness, physiological causes as motion sickness, visually induced in cases of some people who go to heights. When they look down, they feel vertiginous. Sometimes patients complain of benign positional vertigo. That's a cause of peripheral vertigo. When patient complains of vertigo in certain head position, patients also could have Meniere disease when the patient has vertigo and sensory neural hearing loss. Also, the patient could have labyrinthitis or vestibular neuritis, where the patient complains of vertigo and severe vomiting and inability to just raise from a lying position. They feel very vertiginous. Sometimes in patients post-traumatic, usually there could be a perilymph fistula that manifests with vertigo. Toxic causes as some antibiotics as aminoglycosides, some ophthalmological causes, and finally some psychogenic causes. All these causes could cause peripheral vertigo. Central vertigo, on the other hand, could be caused or could be a part of migraine, vertiginous migraine or basilar migraine could present with vertigo. Also, brainstem lesions as vascular lesions or tumors in the brainstem could manifest with vertigo. Cerebellar lesions usually manifest with vertigo, and in some cervical causes, when some patients have cervical spondylosis, when they have some cerebral insufficiency, they could present with vertigo. Sometimes with epilepsy, patients present with vertigo. In CNS infections, it's common that patients have vertigo. Also, in some patients with MS, they could present with vertigo. But we have here to take care that with central causes, usually we have red flag with vertigo. Central causes, it is very difficult that they come only with vertigo in comparison with the peripheral causes. In some peripheral causes, the patient could come only with vertigo. In central causes, usually the patient has vertigo plus a red flag that we will discuss later. This is a table that we could use to differentiate between peripheral vertigo and central vertigo. As we said, peripheral vertigo is caused by a lesion in semicircular canals, in the utricle, on the saccule, mainly in the inner ear. In central vertigo, the lesion usually in the vestibular nerve or vestibular nuclei or their connections in the brainstem. In peripheral vertigo, the vertigo is usually severe and paroxysmal. In central vertigo, the vertigo is usually mild but constant and persistent. The duration of vertigo in peripheral causes is usually short, below 2 minutes. In central causes, vertigo is usually prolonged and persistent. Head movement usually aggravates peripheral vertigo. In central vertigo, it has no effect. Usually, the peripheral vertigo is associated with marked and severe nausea and vomiting. Usually, in central vertigo, nausea and vomiting are less common and mild. Usually with peripheral vertigo, patients come with horizontal, torsional, or mixed nystagmus, but it is never vertical. In peripheral vertigo, it is horizontal or torsional, but never vertical vertigo, and usually unidirectional and dampens by fixation and usually fatigable. In central vertigo, no. Any type of nystagmus could be even vertical nystagmus, and the nystagmus is constant, not fatigable, and usually bidirectional, not unidirectional, as in peripheral vertigo. In peripheral vertigo, it is usually associated with hearing loss, as in patients with vestibular neuritis or patients with Meniere's disease. In central vertigo, as we said, we usually have a red flag with vertigo as ataxia, diplopia, slurred speech, long tract manifestation, and others. And when we approaching a patient with vertigo, we usually, first of all, we search for a red flag. Red flags in vertigo include persistent vertigo, progressively worsening symptoms, vertical eye movement or vertical nystagmus, severe headache, especially in the morning. That's a sign of increased intracranial pressure. And when we find 5Ds, diplopia, dysarthria, dysphasia, drop attacks, and dizziness, or 3Ns, numbness, nausea, and nystagmus, vomiting, mild vomiting, and ataxia, and cerebellar signs and cranial nerve pulses also are red flags with central vertigo. Presence of papilledema, fever, weakness, or Horner syndrome, all these are red flags that when present in a patient with vertigo, it usually denotes a central cause and needs prompt investigation and rapid intervention. Clinically, when we are approaching a patient with vertigo, history is very important. Is it true vertigo or just dizziness? We usually ask about pattern of onset and duration, either acute, relapsing, or constant, or chronic vertigo, any auditory manifestations, any neurological disturbances. Is it associated with syncope? It is triggered by movement or a specific position that denotes benign positional vertigo. It is associated with unusual eye movement nystagmus and the direction of nystagmus. Any past head or neck trauma or injury, past medical history, is the patient diabetic, hypertensive, any vascular risk factors, history of any medications, antibiotics as aminoglycosides, or any other specific drug or alcohol intoxication. Examination, when approaching a patient with vertigo, we usually do general examination, especially vital signs, blood pressure, sitting and standing, to see if there is an element of postural hypotension. Also, we see blood pressure in both arms to search for steal phenomena. Carotid auscultation is important. Also, cardiac and chest examination are important. Neurological examination, including extraocular muscle movements, searching for nystagmus and the direction of nystagmus, and cranial nerve examination, upper and lower limb examination for muscle strength, also gait and cerebellar function, and lastly, repositioning techniques, which is a Dix-Hall bike maneuver, in which we put the head in certain positions to just eliminate the effect of vertigo and see the direction of nystagmus and diagnose cases with benign positional vertigo. Ear examination is also important. Gross hearing plus Weber and Rene tests, external auditory canal vesicles to exclude any infection that could cause vertigo, cerumen and foreign body in the external auditory canal, also presence of otitis media, as we said before, Dix-Hall bike maneuver for benign positional vertigo. After history and examination, we usually do investigation when we are suspecting a central cause. In cases of acute vertigo, brain imaging, CT or MRI brain is a must, especially if there is a red flag. Also, in some cases, we could need vascular imaging as MRA or CT angio. Also, assessment of hearing when we are suspecting Meniere's disease or disease of inner ear. Investigations as audiometry could help. After taking history, doing examination, and performing investigation if needed, we usually come to the management. The management depends on the cause, but in general, symptomatic treatment options include lifestyle modification, proper hydration, decreased salt intake, and use of soft collar in some cases to avoid rapid head movements. Also, sometimes repositioning maneuver done by physiotherapists as Ebley Canalith repositioning technique or Simont laboratory technique helps, especially in cases with semicircular canal dysfunction and benign positional vertigo. Also, some medications could help as vestibular suppressants as beta-histine, sinarzer, or ondansetron, or metoclopramide, which help to decrease vomiting and nausea sensation. Sometimes we need to give patients steroids. In some resistant cases, surgery could be an option. Any questions? Okay, here are some cases that we could just take together just to make sure we get the needed information. Our first case is a 45 years old woman with mild hypertension presents to the emergency department with complaints of severe vertigo, unsteadiness, nausea, and vomiting. These symptoms began in the morning and she had several exacerbations since then, each lasting about a minute and especially with neck extension. Her examination is normal with exception of nystagmus and nausea brought by certain head movements. We are trying to decide if her vertigo is central or peripheral in origin. What would be the next step in evaluation of this patient? This is a patient coming with severe vertigo and nausea and vomiting with no red flags. Vertigo is short in duration and is brought by certain head positions. So, when approaching such a patient, we have no red flags, so we can try a repositioning maneuver that could help us to diagnose benign positional vertigo. In this case, the correct answer is C, Dix-Holbein maneuver. Case 2. In the previous case, which of the following is most suggestive of central vertigo? We remember that central vertigo is usually prolonged, is not suppressed by visual fixation, and it is usually associated with any type of nystagmus, not only horizontal, and usually not associated with any hearing affection. So the answer in here is B, absent nystagmus latency. That goes with central vertigo. All other options goes with peripheral vertigo. In case 3, 76 years old male presented with sudden onset of dizziness, feeling of balance, and he was unable to ambulate on his own. He had history of Bell's palsy, of right facial drop, TIA, cabbage operation, cardiac stents, insertion. This was not associated with nausea or vomiting, trouble of vision, trouble of hearing, no weakness, no numbness. On examination, he had lower limb ataxia. What is the best next step in such a case? In this patient, we have a patient with multiple comorbidities and multiple vascular risk factors, and he has a red flag. So If we have a patient with dizziness or unsteadiness or vertigo and a red flag, we usually go for brain imaging. He may have cerebellar infarction. So the answer in this case is A, brain imaging. And thank you very much for your listening.